So these are my disclosures. And I actually want to first begin with an acknowledgement that I was given a rather ambitious task. How might we translate pathophysiological advances into the clinic in this entity of functional neurological disorder, a condition that really sits at the intersection of brain and mind and neurology and psychiatry. So I'm hoping to do my best, and you'll see there's some gaps, but I'm hoping to give you all a bit of a playbook in how to think about this. So first, a quote from Stanley Cobb. And Stanley Cobb was a neurologist who went on to establish the first department of psychiatry at my hospital, Massachusetts General Hospital. And there are now named Stanley Cobb chairs in the Department of Psychiatry across the Harvard hospital system. And a quote from Stanley Cobb. I solved the mind-body problem by stating there is no such problem. There are, of course, many problems concerning the mind and the body and all the intermediate levels of integration of the nervous system. However, what I wish to emphasize is there is no problem of mind versus body because biologically no such dichotomy can be made. The dichotomy is an artifact. Is how do we think about a given patient's symptoms, either in isolation or their symptom complex? How do we relate symptoms to biologically relevant constructs? And how do those biologically relevant constructs potentially map onto brain networks? So let's use this structure to think, for example, about functional tremor. And to set the stage, I'm sure many of you are familiar, but here's one such video of an individual with a functional tremor. You see a large amplitude postural tremor. Cognitive distractions not particularly influential. Now with a repeating motor pattern. The high amplitude postural tremors essentially gone for a moment. Now there's time locked movement coupled with the finger tapping. We're seeing clear features of variability, distractibility, and entrainment. Very notably for this exercise here, the patient is experiencing their tremulous movements as involuntary. And with those ballistic movements performed with the right hand, you may have noticed a brief pause. All of these are rule-in signs for functional tremor. So let's think about this notion of patients moving and yet not feeling ownership over them. This is a landmark study published in Science in 2009, where a series of patients are undergoing cortical stimulation, awake, in the neurosurgical operating suite. And what they observed as they were stimulating portions of the inferior parietal lobe at low stimulation is that individuals reported a sense of wanting to move. At higher stimulation, they actually verbalized, I move, when in fact there was no movement performed. And this teaches us in part, in addition to a range of other scientific findings, that one sense of ownership over movement occurs in part by having our primary sensory motor areas send an accurate copy of what the expected sensory consequences is of our anticipated movement to portions of the inferior parietal lobe. And the inferior parietal lobule and related temporal parietal junction are then creating a calculation, anticipated sensory consequences, and actually realized sensory consequences. Do they match up? And that matching allows us to experience our movements as volitional. In an early landmark paper by Mark Hallett, Valerie Boudin, they had a relatively unique cohort where individuals had a positional functional tremor. So in position A, individuals were shaking and feeling as though they were not in control of their movement. In position B, the individuals could mimic their tremor, and yet in position B, they felt the owner of their movement. They had the component of volitional quality. And when you compared position A, functional tremor, versus position B, feeling in control of your movement, they observed hypoactivation of the right temporal parietal junction. When they performed connectivity analyses, they also identified aberrant connectivity between the temporal parietal junctions and sensory motor areas, among other things. This led this group to surmise that an important construct in the pathophysiology of functional neurological disorder was this sense of impaired action authorship, impaired self-agency, with an important role for the TPJ, the temporal parietal junction, and its connectivity. So this brings us back to this notion of symptom. Here we're talking about functional tremor. Tremulous movements and not feeling the owner of those movements. The implicated biological construct, impaired self-agency, and the implicated circuit, the right temporal parietal junction, and its related connectivity to sensory motor area. So let's expand. Let's now think about paroxysmal functional motor presentations, as well as individual functional seizures. How might we develop a similar playbook to conceptualize this possibility? Again, just to sort of bring this center of mind, here is an individual into the epilepsy monitoring unit. Hypermotor movement, eventually those bicycle movements may have you think about frontal lobe epilepsy. But now there's a different frequency of the movement. There's low amplitude, there's tremulous. The movements stop and start.
Lift your right leg up in the air.
They pick up a similar pattern, but in slower rhythm.
Lift your left arm up in the air.
Can't see it very well, but the patient's eyes are tightly shut. Some of the semiological features that help us make a diagnosis of functional seizures. And this patient's EEG before, during, and after the event, apart from muscle artifact, was essentially normal, lacked an epileptiform correlate. So how do we think about this presentation? And another nugget here as I think about this presentation is I've been struck clinically that oftentimes in the clinic, I can prevent patients from having events. I recognize that they're becoming hyper-aroused. I recognize they might be breath holding. I potentially recognize different patterns as if they're disconnecting. And if I intervene and ground them, or if I intervene and pause my interview and really have them focus on relaxation exercises, in many instances, I can prevent events. What I've noticed as well is once an individual is having a functional seizure, I don't have the same success in modifying the event itself. If anything, it's as though the event needs to happen. And if we are fighting the event psychologically or physically, it just seems to prolong the event. So this was sort of a clinical pearl that I have gathered through observation. And now I'm going to bring in some of our neuroimaging research. This is resting state functional connectivity analyses. This is work led now by an assistant professor here with us, Ibai Des. And we're using a hybrid technique that employs both components of graph theory and seed-based functional connectivity. It's called stepwise functional connectivity. And let me walk the group through some of this here. So first you have to identify a seed or area of interest. And in this case, it's the primary M1 region, the hand region. And we're able to ask, what is the most tightly coupled connectivity between M1 and other broadly distributed brain areas? And you can see that most robust tightly coupled connectivity as highlighted in green. Now, that connectivity between blue to green represents the first link step connectivity. Now what happens is our seed, our region of interest, moves from M1 to that neighboring connectivity, the regions in green. And we ask what areas are tightly coupled to those green identified brain areas or voxels. That green to yellow pattern identifies the second level link step connectivity. And you can do this iteratively. This has been done in healthy subjects. And when you begin from primary sensory motor areas, from primary auditory cortex, from primary visual cortex, what's been described is that there's convergent connectivity to multimodal integration brain areas, highlighted in green if you can see my arrows. This includes the dorsal anterior cingulate, the anterior insula, the temporal parietal junction. Notably, the most integrative are the cortical hubs in blue. And you might recognize the cortical hubs, particularly at the midline level, as being core components of the default mode network. But the green areas, these multimodal integration brain areas, caught my attention because these are the areas implicated across studies in the pathophysiology of functional neurological disorder, at least to some degree. And we asked the question, might we look at information flow or link step connectivity from primary motor areas and also from discrete nuclei of the amygdala, including the lateral basal portion, which is the sensory portion of the amygdala. So we performed this in a cohort of patients with FND compared to healthy controls. And what we observed was enhanced or increased link step connectivity from primary motor areas to the bilateral posterior cingulate. Posterior insula, excuse me. To the bilateral posterior insula as identified in link step 2 and in link step 3. Now, when you began bottom up from the sensory portion of the amygdala, the lateral basal, here we appreciated increased link step connectivity to the anterior insula. So whether you began from primary motor or from bottom up sensory amygdala, it seemed as though there was a bit of a traffic jam at the level of the insula, anterior and posterior. We also observed subcortically increased link step connectivity from the sensory portion of the amygdala to subcortical structures, including the periaqueductal gray. Now, the implications of this are speculative. Okay, I really want to highlight that. But I think that they're at least hypothesis generating and intriguing. And notably, we're not the first group to identify functional activation patterns in the PAG related to FND in comparison to healthy controls. Here's a task-based fMRI study from Richard Cannon, Anthony David, and others, led by Selma Ibeck and Tim Nicholson, identifying hyperactivation of the periaqueductal gray in patients with FND in specific contrasts. So let's think about this from a structural anatomic perspective as well. And here, if you think about the amygdala, we have sensory information converging on the amygdala in the lateral and basal nuclei. There are a series of connections across nuclei, and the central nucleus is your outflow, including driving activation of the periaqueductal gray. We know that the PAG is involved in primitive defensive behaviors, including freezing and fight or flight response, also tonic immobility. And so we speculate, but potentially informed by the neuroimaging findings and informed by structural and functional neuroanatomy, that might a component of what we see in these major motor functional seizures and paroxysmal whole body shaking events with preserved awareness that we sometimes see in our functional movement disorder patients. Might this be interpreted as abnormal activation of primitive non-conscious defensive behaviors. And might this be driven in part by an amygdala to PAG hyperconnectivity? Not clear, but at least we're beginning to build portions of the model that we can test. Another feature here that relates to this circuitry is another clinical observation, one that we've operationalized using psychometric measurements as well. And that is this notion of sensory processing difficulties in patients with FAAN. Many of you may observe that bright lights, loud noises, body pain seem to trigger or amplify the patient's functional neurologic symptoms. We've looked at this with our occupational therapy colleagues, and we've been able to replicate our initial findings in a paper currently under review, including highlighting extreme tendencies towards sensory sensitivity and sensory avoiding, among other features. So notably, the sensory portion of the amygdala receives direct thalamic sensory information, thalamo-amygdala connectivity. And might this sensory experience triggering primitive defensive behaviors relate to what we're seeing here? A thalamus to sensory amygdala to central nucleus to PAG circuit. Again, hypothesis generating, but driven by neuroscientific formulations. Let's think about another common clinical scenario, and that is FND symptoms triggered or intensified by arousal, not always negative arousal, and emotional states. And this has us think a bit about the history of functional neurological disorder and its prior formulations. What caught my attention early on in my interest in this work is that several studies had reported associations between the magnitude of adverse life experiences, particularly the magnitude of childhood adverse life experiences, maltreatment, and markers or indices of symptom severity. Keeping that in mind, we also know that there's quite a bit of literature identifying that there's hyperactivity and hyperreactivity of the amygdala, as well as hyperconnectivity between the amygdala and motor control areas. Notably, not only is the amygdala hyperconnected to motor control areas, but other studies not shown here have shown that the cingulo-insular brain areas, including the insula, are hyperconnected to primary motor areas as well. Here I'm highlighting our molecular psychiatry study from 2021. Notably, this was one of the first studies to bring in psychiatric controls, something that we continue to emphasize in our research program currently. Our psychiatric controls were individuals with clinically salient lifetime histories of depression, anxiety, and trauma-related conditions, a mixed cohort. Notably, our psychiatric controls were, by convenience, frankly, because we recruited from the community, were matched to our FND sample in terms of the magnitude of previously experienced adverse childhood experiences, specifically and including childhood abuse. So we had an opportunity to ask the question, might the resting state whole brain connectome, the organizational profile, be influenced differently in patients with FND compared to psychiatric controls as it pertains to important risk factors, in this case, physical abuse? And what we showed in this small cohort, again, in need of replication, but intriguing, is that there appeared to be a dose-dependent response. And that is that the magnitude of connectivity between the amygdala and primary motor areas increased the more an individual self-reported having experienced a greater severity of physical abuse. The same correlation was not observed in our psychiatric controls. And we were able to show this for the bilateral amygdala as well as the bilateral insula. In what we're deeming our sort of initial or older cohort, we've moved on to collecting a new cohort that we're currently analyzing and soon to write up findings on. In our earlier cohort, our last published work aimed to ask this question: how might we think about a trauma subtype of functional neurological disorder? And how might one operationalize that? Succinctly, what I'll say is that individuals with FND who self-reported moderate to severe childhood abuse across physical, emotional, and sexual domains reported at group level higher symptom severity in terms of the SDQ and higher somatic symptoms than individuals with FND who did not report moderate to severe childhood abuse. That's seen in the middle panel. The findings were even more robust for FND with or without probable PTSD, and notably absent when we stratified by neglect. More work to come here, but I think an interesting question to think about: might there be a trauma subtype of functional neurological disorder? And really interesting, by the way, is classical psychiatry and biological psychiatry have been interested in the intersection of mental health and trauma for quite some time. There's now a literature to suggest that conditions like migraines and Parkinson's disease may also have a trauma subtype. So potentially this notion of a trauma subtype is a transdiagnostic predisposing vulnerability that certainly I think warrants further investigation. So coming back to our rubric for how to frame clinical observations using biological constructs, this notion of FND symptoms intensifying or being triggered by arousal or affect, particularly if occurring in the context of individuals with prominent adverse life experiences. Might we be seeing heightened limbic influence over motor performance? And might that heightened limbic influence over motor performance relate to aberrant and increased salience network connectivity to sensory motor areas? A hijacking, so to speak, of normal motor control by this intrusion. And notably, the salience network includes amygdalar nuclei, the anterior insula, the dorsal anterior cingulate, and the periaqueductal gray. So this is something where I certainly don't think of FND as a singular network problem, but it's a multi-network problem, including abnormal interactions across networks. But this is really a nice image and a point to emphasize. I think the salience network plays an important role. Okay, I think we have two more topics to cover. And this topic here is based on published reports, really, that a subset of patients with paroxysmal functional neurologic symptoms, including those with functional seizures, some will spontaneously endorse, others by direct questioning, note heart racing, shortness of breath, nausea, feeling tremulous, and yet seemingly without the co-occurring feature of panic. This notion of panic attacks without panic. This here led us during the pandemic really to collaborate very closely with Lisa Feldman Barrett. My joke amongst my research team is that we all sort of went back to graduate school for a year or two to really bring in the updated clinical neuroscience of predictive processing. And part of this is this notion that we predict before we experience. And in fact, we develop a great repertoire of concepts, sensory concepts, across various domains, linguistic concepts through one's development, but also maybe emotions being acquired and refined concepts as well. So this notion of experience where we predict a given concept, we have a sensory percept, we're looking for a match, prediction matching to incoming information. And at times there's mismatches, and that activates a prediction error, and you may learn or not learn that prediction error. Obviously, a lot of nuance to this notion of predictive processing, but concepts, predictions, prediction error. And the work of Lisa Feldman Barrett has really highlighted that emotions are constructed. And in fact, we issue anticipated emotion concepts or emotion experiences, which are very quickly matched to sensory experiences. And at times, there's a bit of a prediction error. And under this sort of theory of we construct emotions, and our emotion template or range of constructs are acquired in life and refined, also means that our template of emotion concepts are not universal and may vary patient to patient. And if one keeps that in mind, then one can theory that for the same sensory experience, heart racing, shortness of breath, palpitations, nausea, feeling tremulous on the inside, might one be issuing and matching those sensory experiences to a non-emotion concept, including potentially health-related concepts? And might this notion of a difference in either one's emotion concepts and non-emotion concepts, or a difference in when we issue them? All the concepts might be reasonably the same, but there are instances when we don't issue an emotion concept, but we issue a non-emotion concept. And it matches for the exact same sensory experience. Might this allow us to understand notions like panic without panic? Really, this is at the level of the theoretical, but it brings in this notion of predictive processing. And as we bring in this notion of predictive processing, it's important to also note that the cortical hubs, including the default portions of the default mode network, are thought to be involved in the issuing of conceptual predictions. And notably, the salience network is thought to be involved in highlighting the importance of prediction errors. Are we learning or not learning from the persistent mismatch that might be occurring? And these notions of concepts and prediction error learning relating to the default mode network and the salience network offer complementary explanations of these brain areas' role in the pathophysiology of FAAN. So in our playbook here, so to speak, Panic Without Panic, a theorized construct is aberrant emotion construction at play. And are we seeing abnormal crosstalk between the default mode network, the salience network, and sensory motor networks? Last theme, and I'll be succinct here, is this notion of functional neurological disorder with a capital F. Well, it might not be so functional in the sense that structure-functional relationships are closely coupled. This is no surprise to us in psychiatry and biological psychiatry. There's a structural neuroanatomy for major depression, for post-traumatic stress disorder, for schizophrenia. So this, I think, somewhat artificial dichotomy of functional problems and structural problems likely needs a more nuanced conversation, even in functional neurological disorder. And this is where research in my lab, frankly, began in identifying relationships between gray matter profiles and indices of symptom severity and childhood abuse burden, as well as looking at cortical thickness measures. And no surprise, as we think about networks, we can think about gray matter areas and gray matter areas connecting to other gray matter areas through white matter tracks. And some of the tracks that also related to indices of symptom severity were the tracks like the medial forebrain brundle or the stria terminalis fornix, which are tracks directly related to many of the brain areas and circuits we've talked about in the course of this talk. So I'll wrap up there. I really appreciate the opportunity to visit with you all from afar. And I realize I want to just give an extra shout out to Professor Richard Cannon, who I've had the opportunity to exchange ideas with in the past. And we have such a great community in the F&D Society. I look forward to seeing some of you personally in Verona. And I just want to thank my team as well, many of which are highlighted here. You have my contact information, but my email is on the slide in case you need it. Thank you.
David, thank you so much. I mean, we did give you an ambitious task, and I think it's safe to say you more than fulfilled the brief.